35-year-old patient with history of non-ischemic cardiomyopathy on heart failure therapy with IV milrinone, presented for orthotopic heart transplantation, no anticoagulation, no renal or hepatic insufficiency, no significant pulmonary hypertension. So no risk factors in the recipient. Donor is a 25-year-old traumatic brain injury with a good biventricular function, in-house donor. So donor is also low risk. So you expect, this is the heart which is pre-bypass recipient heart. You can see the EF is around 10 to 15%. Dissection, heparinization, cannulation, uneven full, heart brought from the other operating room in cold preserved state. So this is an in-house donor. You are taking out the heart from the same hospital and putting in the same hospital, like Indian setup. Many Indian hospital do that. There is no transport time, there is no ischemic time. The donor is good, the recipient is good. There is no reason this heart is going to fail. Anastomosis, uneven full aortic cross clamp removed after salmeterol 500 milligram. SVC anastomosis was finalized. Reperfusion was done with a map of 70 millimeter mercury for 30 minutes. Epinephrine was started. After termination of cardiopulmonary bypass, this is the cardiac function. You have good biventricular function. As I told you, the images in the post-bypass period may be grainy, may not be optimum, but you will be able to make diagnosis with that. So 4-chamber view, good cardiac function after prodamin. Chest closure also was uneven full, no change in cardiac function. You can see the left ventricle is uniformly working fine, right ventricular function is fine. So this is what expected in a heart transplant. You have a recipient with no other risk factors. You have a donor, young donor, male without any significant cardiac disease. You have no increase in ischemic time. So all three go together and the heart works fine. So now going to the second case, a 58-year-old male, history of ischemic cardiomyopathy, mild COPD, the transpulmonary gradient is 12 millimeter of mercury. I will explain what that is. A transpulmonary gradient is the difference between a mean pulmonary arterial pressure minus PCWP, but it's a left atrial pressure or pulmonary capillary wedge pressure. So the transpulmonary gradient is used to differentiate a cardiogenic pulmonary hypertension from pulmonogenic pulmonary hypertension. So is that pulmonary hypertension is because of left ventricular failure or is it because of COPD? So that can be easily differentiated by transpulmonary gradient. If the transpulmonary gradient is more than 12, that indicates the PA pressure increase is because of either pulmonary cause, COPD, sleep apnea, pulmonary fibrosis, or something like that. That is not ideal for a heart transplant patient. But if the transpulmonary gradient is less than 12, that pulmonary hypertension is probably related to cardiogenic pulmonary hypertension. So that resolves once the recipient old heart is taken out and the new heart is implanted. So that's a good sign. So here the PA systolic pressure is preoperatively was 35. It is high, but the transpulmonary gradient is borderline. It's not low, it's not too high. So this heart will tolerate the recipient implantation.